So let's look at bacterial diseases of the skin, and we will start with diseases caused by Staphylococcus aureus. And what we will see later on is that some of these diseases are as likely to be caused by a Streptococcus species. And it matters. That distinction really does matter because Staphylococcus species are resistant to a lot of antibiotics. Streptococcus species are not. So it's easier to treat a streptococcal infection than a staphylococcal infection. Another point is that Staphylococcus aureus is the SA in MRSA or MRSA, and any disease caused by Staphylococcus aureus can be caused by a MRSA strain. A MRSA strain is just a strain of Staphylococcus aureus that has resistance to the newer penicillins like methicillin, and typically that means they have the mutant transpeptidase that makes them resistant to all beta-lactam antibiotics. Just keep that in mind, is that any of these could be caused by MRSA strains or they could be caused by non-MRSA strains. Okay, so when we think about staphylococcal skin infections, it can be complicated because we do wonder, do they come from the normal microbiota or not? And they'll have general, hard to distinguish signs and symptoms. So some things to think about are, what is Staphylococcus aureus like? And some of these I've mentioned. The durability is very important. The reason it's so abundant and so hard to eradicate from clinics is that it can live on a wall just fine. It's not going to grow without water, but it also isn't going to die without water. And so when a bacterium thinks about living on a wall or floor or the ceiling, that is a desert. That is a dry environment where it doesn't have the water it needs to divide. And that kills most bacteria, but not Staphylococcus aureus. The textbook says it's the most durable organism after endospores. So Staphylococcus aureus would be the most durable bacterium that is not an endospore. So that's kind of a bold statement, and it does help understand why it's such a problem in clinics. And so a lot of this I've mentioned already. Here are some virulence factors I want you to think about. Coagulase, again, is a big one, and that protects them from macrophages. Hyaluronidase allows them to penetrate connective tissue. Exfoliatins, these are a group of different toxins that cause epidermal layers to separate from each other and fall off, and that is major skin damage. And toxic shock syndrome toxin is a superantigen, and we'll talk more about both of these. The enterotoxins will irritate the gut and cause diarrhea. And so some of these strains will release all of these. Some Staph aureus strains will release all of these toxins, and so the patient will have diarrhea. Their skin will be falling off, and they'll have massive T-cell responses that lead to extreme low blood pressure and death. So it can be a crazy situation when a person has a staphylococcal infection, or many staphylococcal strains won't release any of them. And so that's much more common, is that none of these are released. But we see diseases, when these are released, we see the specific diseases we'll get into. So the first disease we'll look at is Impetigo, and this is a really contagious disease caused by Staphylococci and Streptococci, typically in children. And it affects the epidermis. Whenever the bacteria can get into the epidermis, they can cause formation of these rashes. And like I said, it's highly contagious. And what it's caused by is the exfoliatins. So these are these are encoded by a bacteriophage that can infect Staphylococcus aureus, and so the strains that have been infected by that bacteriophage can cause this disease. And so what happens is the desmosomes that connect cells within the epidermis get disrupted. And so in some cases, cells lose their strong connections, and it weakens the epidermis. And so blisters form between two different layers of the epidermis. So between the actively growing cells and the cells that are transitioning into the keratinized state, so these would be the actively growing cells, and these would be the ones transitioning into the keratinized state. These layers would separate, and the separation fills with fluid, and that's a blister. So most Staphylococcus strains cannot cause impetigo. And that's a point I want you to keep thinking about, is that in many cases the virulence factors determine what disease happens. The first disease we will look at is impetigo, and this is a very contagious disease that typically affects young children in warm, humid climates. And this is a situation where the bacteria can get into the epidermis through a break in the skin, and they release an exfoliatin, and so that causes blistering. It's very contagious, and it can be treated and prevented. Typically, prevention would be separating children from each other so they can't touch each other, and considering the wounds to be infectious. And so covering the wounds, and preventing contaminated materials like bedding and clothing from being shared, that can prevent spreading of impetigo. Treatment would be antibiotic treatment, and that's pretty straightforward. Prevention is always better than treatment. Anyway, impetigo happens when a strain of Staphylococcus aureus is able to cause an infection and release an exfoliatin. So what does that mean? Well, what these exfoliatins do, what they do is they disrupt desmosomes in the epidermis, and that allows the stratum spinosum to separate from the stratum granulosum. So this would be the actively growing cells in the epidermis, and this would be the cells that are transitioning into the keratinized state. And so the blisters form when these two layers start separating from each other, because the strong bonds between the cells start breaking down. And this only happens if the Staphylococcus strain that's infecting the person is infected itself by the bacteriophage that carries these genes. And so, most staph strains cannot cause this. And I mentioned on the previous slide, this can also be caused by a Streptococcus strain, and it's actually more commonly caused by that strain. But you'll see when we get to the streptococcal section why we brought it up here. In many cases, you will see Staphylococcus in those lesions. What's more commonly caused by Staphylococcus is folliculitis. This is an infected hair follicle. So it's like acne, but it's deeper. It's all the way in the hair follicle itself, not in the upper layers of the epidermis. Typically, it's just because the follicle has been blocked. So it's similar to acne in that way, but like I said, deeper. And so what can happen, and so this would be an irritation situation. What can happen sometimes is bacteria manage to escape from the hair follicle, and that's when we get a boil or furuncle. And this is where I have the invasive symbol surrounded by the circle, because what's going on here is bacteria are escaping into the dermis, and they're being walled off into a small abscess. And so this can be a complication of folliculitis. And so what we would see would be swelling of the epidermis because of an immune response happening in the dermis. So it's kind of complicated, but the infection is in the dermis. the boil you see, this is all things that are happening in the epidermal layer. The distension of a boil, so the fact that it's being pushed up out of the skin, can be partly from swelling in the dermis, but most of it's going on in the epidermis. And we would contrast that with a carbuncle. This is a deeper, usually bigger abscess caused by Staphylococci, that it can again start with folliculitis, and a boil can turn into this. And this is where there's a much bigger, deep abscess in the dermis or hypodermis, and as it grows, it causes the skin to become distended. And so you'll see a lump. So you'd feel a lump under the skin, and the skin would be bulging outward. And carbuncles are the most serious of these that we've seen so far because they're large and there are a lot of opportunities for the bacteria to escape and get into the blood and lymph. And when that happens, you get strong immune responses. And also, just from the size of the infected area, a lot of the signals released by the immune cells will circulate through the body. And so this can also give rise to a systemic infection where Staphylococcus themselves are circulating in the bloodstream or the lymph, and they can go to other sites in the body. And so, again, furuncles and carbuncles are types of abscesses. These are basically accumulations of pus, but it can only accumulate because there's some walled off area. So the immune response is sealing it off. And these can be deeper than the cutaneous and subcutaneous ones I've been talking about. But furuncles and carbuncles are what we think of as kind of superficial abscesses. In other situations, abscesses can happen in the peritoneum. If there's any leakage from the gut, for example, our bodies are pretty aggressive about walling that off if they can. And there's not much more to say about that. And we'll cover those things later in Unit 4. Again, I want to point out that MRSA strains can cause any of these. So what we'll often see is that the deeper infections are caused by the MRSA strains. And I want you to remember, in general, virulence is based on virulence factors, not on antibiotic resistance. So if I say a MRSA strain, you should not immediately think a highly invasive, dangerous strain. But in the case of MRSA, they live in clinics. They can survive on walls and in floors and on instruments, anything that's not sterilized. And what that means is that a patient with a MRSA infection that escapes antibiotic treatment, well, it's going to keep being selected for the ability to cause disease, the ability to keep that infection going. As long as the antibiotics don't work, the bacteria keep growing in the body, and every time they divide, that's a chance for natural selection to push them towards better ability to hide from the immune system or better ability to invade tissues or whatever. And so those bacteria that are going through that selection, both for antibiotic resistance and for greater virulence, well, they're in clinics. Patients who have those are in clinics, shedding those bacteria, contaminating their rooms. And so there is a correlation between MRSA strains and virulence for that reason. And at first, this was what people saw happening, and it was scary when people started getting MRSA infections outside of the clinic. So that was a new thing. I remember seeing books 10 years ago that said community-acquired Staphylococcus aureus is scary. So that brings us to some of the more frightening diseases caused by Staphylococcus, like scalded skin syndrome. And this is where a wound infection, some kind of infection, typically people with weakened immune systems, like infants and older people, they'll have a bacterial infection caused by Staphylococcus, and those cells will release exfoliatins into the local blood supply. So whatever part of the body they're infecting, the capillaries end up carrying these exfoliatins to the epidermal layers. And so you'd see exfoliation. You'd see regions where the epidermal layers separate and top layers come off, and that is a bad and painful situation. Treatment, this is where I have both, excuse me, I have both of these things up here for a reason. Treatment of this kind of thing can be two-pronged. It can involve both trying to get rid of the toxin, since the toxin is what's doing the damage, and getting rid of the bacterial infection. And so that is a thing to think about, is if the toxin is doing all the damage, killing the bacteria doesn't get rid of the toxin right away, and so you do have to think about that. Typically with scalded skin syndrome, if the infection is treated, that's all that's necessary, and an infant would recover quickly. But if it's not treated, it can be serious. So here's what it could look like in an adult, where there are just large regions of exfoliating skin. And so this picture, I think it shows a simpler situation that's easier for me, at least, as a non-clinician to understand, because I see this line here where it appears that layers of the epidermis, some layers have disappeared. And I don't know what layers those are. I can't say for sure which layers the person has lost other than the most superficial layers. But again, that's what the exfoliatin does. This whole region has separation between layers of the epidermis. And so ultimately, the superficial layers are going to come off and have to be replaced from underneath. The last and most serious of the staphylococcal diseases we will look at here is toxic shock syndrome. And this is critically serious when it happens. There's overlap between this and scalded skin syndrome in that exfoliating toxins would circulate in the bloodstream. The difference is that toxic shock syndrome is systemic. So a person could have that exfoliation on both hands, for example. And you wouldn't expect that with scalded skin syndrome. It's a really weird situation. We don't quite know what causes this. We know how it happens. We understand the pathology of it. We don't understand why the bacteria decide to release the toxic shock syndrome toxin. So the toxin that causes all the extreme effects, we don't know the trigger that causes Staphylococcus aureus to release it. So in order to see this disease, you need to have Staphylococcus aureus in the body that are able to make this toxin and have decided to release this toxin. And that decision is what we don't understand. But the risk factors include long-term tampon usage and different kinds of infections, many of which are centered around the female reproductive tract. But in other cases, any wound can host a staphylococcal infection that can lead to this. So again, it's a strange situation. And I put all these up here because this can happen during a systemic invasive staphylococcal infection, or a situation where the bacteria aren't really even growing inside the body. So in the most famous situation, this disease was first seen when superabsorbent tampons were made in the 1970s, I believe. And it's not really a bacterial infection in that situation, because the bacteria are in the lumen of the vagina. And so they aren't really invading the tissue, but they are releasing this powerful toxin. If it were always because of that, I would only have this thing here. But since there are other situations like wound infections that lead to this, any of these things can cause this. So how it works is the toxin enters the bloodstream, and it leads to whole body overactivation of an immune response. Basically, T cells, helper T cells, are activated, and they will inappropriately activate huge quantities of monocytes and macrophages. And ultimately, what that's going to lead to is a precipitous drop in blood pressure that can lead to organ failure. And so this is a picture of a person who has toxic shock syndrome, and it's the same kind of things we saw with scalded skin, except this could be an entire limb or multiple limbs that look like this. The toxic shock syndrome toxins are super antigens. So what that means is they activate the immune system. And what they specifically do is they make the T cell think it has recognized the epitope presented by MHC2. So when a T cell looks at an antigen-presenting cell, so an immature T cell, or a naive T cell, I should say, looks at a dendritic cell, and it's asking, should I become active? The answer is always yes if there's a super antigen there. And that's completely inappropriate. So what happens is lots of different T cells will go out into the body and think that they are part of an immune response. And they'll find macrophages. So this could also be a macrophage. And what's happening here is the macrophage is asking, should I become more active? Should I penetrate tissues? Should I do lots of phagocytosis? Should I release cytokines? And the T cell will say, if this is here, the T cell will always say yes. So the super antigen just makes every T cell, every helper T cell interaction into a yes answer. So ultimately, damage all over the body leads to blood leaking into the tissues as they become damaged from blood cells escaping from capillaries, and that can lead to organ failure. So these are the major signals that we see in inappropriate amounts, and they lead to capillary permeability. But since I didn't cover these in my immune system review, you can skip this slide if you want to. Just know this. The superantigen is going to lead to T cell activation, and monocytes and macrophages will be activated, and ultimately that will lead to increased capillary permeability. The blood volume decreases, and that screws up everything in the body. So the staphylococcal diseases, I don't know, there are more, and they overlap a lot with the streptococcal diseases, as you will see. And so between the staphylococcal diseases and the streptococcal diseases, you will see a spectrum of different diseases. And if you see them in the clinic, you can have a guess about what's causing it, but you'd better get the right answer, because the antibiotics you'd use to treat it would be very different. So with that, I'm going to end this video. In the next one, we will look at streptococcus.